CKD, mineral MBD, chronic kidney disease, mineral bone disorders. The renal failure has decreased conversion of the 125 dihydroxyvitamin D3 and D2. Thereby, they have rachitic changes. Also, some amount of cases you have extraosseous presentations, and of course, biological alterations like hypercalcemia, hyperphosphatemia, and hyperparathyroidism, vitamin D decrement. You have decreased mineralization, you have decreased bone volume, you have decreased linear growth, you have decadic deformities. There can be vascular calcification and soft tissue calcifications. The renal osteodystrophy, the term is usually confined to bone morphology secondary to the CKD MBD. There can be high turnover bone disease when parathyroid hormone is elevated, and you have little bit of bone thinning. Osteitis fibrosa cystica is also possible. In low turnover disease, you have the dynamic bone disease. You have suppressed PTH by dint of excess use of the vitamin D, calcium, and there is uremic toxins contribution, altered cytokines, and growth period abnormalities. So CKD-MBD has, apart from that, increased amount of the FGF23 fibroblast growth factor than and its cofactor clotho expressed in the your proximal and distal tubule when it's needed for the FGF23 receptor activation. So FGF23 and clotho, what they do, they have they have a hypophosphaturic effect, and thereby phosphopenia, and thereby rachitic changes. When GFR declines to less than 60 ml per minute per 1.73 meter square, you have secondary hyperparathyroidism. Where it goes unabated, you have tertiary hyperparathyroidism, and it can go on doing the harm even up to the transplant. And rarely, very rarely, you can have neoplastic transformation of the parathyroid gland. These children do have low vitamin D receptor, and they have their decreased calcium sensing receptor activity. So the presentation is rachitic, and the necrosis of the vascular necrosis of the bones and tendon rupture, meniscal ruptures, and your corneal band keratopathy, that is red eye, the conjunctiva, and also the cornea, and the your ischemic skin, muscle, and the soft tissue lesions due to calciphylaxis, and thereby as important restrictive lung disease, visceral calcification is possible. Lung disease in the CKD MBD little bit progressive, though rare, but is of bad prognosis. And diagnosis of disease is by raised ALP, alkaline phosphatase, the calcification of the by X-ray, and the low calcium and little bit raised phosphate, and PTH, and finally your product of calcium and phosphate may be elevated. Bone biopsy is diagnostic, accurate, informative, but rarely practiced globally. And echo can say the calcification and your coronary artery and valvular sites. Now, treatment is phosphate restriction. Now, phosphate restriction reduces the choices of the food, thereby child can turn cachexic. So keep these things in mind when restricting phosphate. Phosphate binders like the calcium acetate and calcium carbonate are useful in hypocalcemic or normocalcemic, where they have rachitic changes, hyperparathyroidism. Sebelum are the non-calcium binding containing binders useful. They will also lower the lipid, and currently lanthanum and your sucroferric oxyhydrate, they are also used globally. So hemodialysis and PD prescriptions must be manipulated to have the better clearance of the phosphate, and high flux dialysis can be used. Optimum dialysis must be ensured, and PD prescription can be changed from the APD to CAPD, and your indwelling catheter can be a little bit of longer time. They have for optimum dialysis, you should give vitamin D in the form of cholecalciferol, and vitamin D analogs like pericalcitrol and others can be used, but they will never give megadose because it is found to have higher amount of nephrocalcinosis and your renal impairment. So apart from that, the cardiac effects of the megadose is not that good. It also decreases the appetite. So it's not the practice. Rather, is a contraindication of giving megadose in the stress therapy in the CKD. And surgical and medical nephrectomy. Now, your parathyroidectomy can be done with the senacalcet or etiocalcetide in children and adults, and rarely you do need to go for the surgical parathyroidectomy.